Thanks. Thanks, Grace. Thanks. My topic, good morning. Although it says evidence-based planning, I'm not going to talk about what is evidence-based planning, the theory, because you guys know better than I do. What I'm planning to talk today is how do you translate evidence-based planning, the planning into action? It's based on my own personal experience. I have been with the University of Addis Ababa University for more than 50 years teaching pediatrics and neonatology. It was in 2003 that the government asked me to write the National Child Survival Strategy. And I didn't know what to do and how to write that strategy. We started searching for literature. It was me and Professor Mokonnen. And the minister, what he asked was, I really want a roadmap that will take this country to achieve MDG4. So the experience then, which we started there, was to do a situational analysis of maternal, newborn, and child health. By situational analysis, we mean the epidemiological profile. How many children are dying? How many mothers are dying annually? What is the trend of mortality for the past 10 years, 20 years? What are they dying from? And for each cause of this, what can you do? This is what we mean by situational analysis. That's the first exercise we did. The next one was identifying the major health system bottlenecks. Knowing the epidemiological profile alone, knowing the cause of death was not enough. If you want to scale up, if we want to improve coverage, then you should identify the major health system bottlenecks and mitigate them and address them. And when I say health system bottlenecks, I'm talking about the supply side and demand side bottlenecks. How are you going to analyze? How are you going to identify, and how are you going to mitigate? Now, the third component was, okay, if you know the health system bottlenecks, if you know the causes of death, then how are you going to package the so-called high-impact, cost-effective interventions to address those bottlenecks and to address those major causes of death? So integrating the high-impact intervention so that 2 + 2 is more than 4. If you do them separately and if you do them in a comprehensive way, the impact is different. So that was another area that we were trying to look at. And the other component that we looked at was delivery vehicles. Okay, you have the interventions, but the interventions do not jump and go to the needy mother, to the needy child. So you need to have a vehicle which can carry those interventions to go to reach to the mother and to reach to the child. So we call them a delivery vehicles. By delivery vehicles, we mean those established programs like antenatal care, like postnatal care, like MNCH, like EPI. These are vehicles. They carry the intervention to the child, to the mother. So we call them health service delivery vehicles. And the last one was the most important one probably for developing countries, the mode of vehicle, the mode of service deliveries. Which mode is appropriate for Ethiopia? Which mode is appropriate for Zimbabwe? Community-based, facility-based, outreach, schedulable services. Those are the kinds of questions that we have asked to ourselves and tried to answer. Situational analysis, the first thing that what we did in Ethiopia in 2003 was maternal and child mortality trend, what are mothers and newborns dying from, the high impact intervention for each target condition, and current status of coverage. Where are we now? Antenatal care, postnatal care, EPI. So those are the kind of exercise that we did. And I'll try now to talk about how we approach this in the two different contexts. The first context that I'm going to talk about, how we did a supply side bottleneck analysis and try to make a huge change in a country which was politically fragile. Well, I know you can challenge me. What do you mean by politically fragile? In a country where the system was almost in a near collapsing state, where maternal mortality ratio has gone up for 20 years. For me, that is a serious challenge. This was in Zimbabwe. When I went there as the Chief of Health and Nutrition for UNICEF, this was the situation that I faced with. Since 1990, in 1990, this was one of the best public health systems in Africa. The best. Maternal mortality ratio in 1990 in Zimbabwe was 390 per 100,000, while Nigeria had 2,000 per 100,000 live births. Zimbabwe had 390. So what happened since then? Because of a political challenge, the maternal mortality went up. Regression of milestones from 390 to 960, DHS result, 2010. 960. So after I reached Zimbabwe, Harare, the first 2 months was to study, to understand what has happened to the system. And after 2 months, I went and talked to the minister. Sir, your system is in a near collapsing state. We have to do something. And he laughed and he said, you've been here only for 2 months, Dr. Assaye. How can you come to that conclusion that my system is in a collapsing state? And my answer was simple. I don't need to be here for 10 years. I don't need to check 100 indicators. There is one indicator which I call it the pH meter, the acid test for the health system, whether it's working or not. And that pH meter is maternal mortality ratio. If the maternal mortality ratio is going down, there's no doubt this system is working well. If it is static, there's no doubt this system is not working well. If it is going up, there is no doubt the system is collapsing. And that's exactly what I told you. So what then? Allow me to investigate, sir. This is what I did in Ethiopia, and this is what I'm going to do in Zimbabwe. Allow us to investigate what are the major health system bottlenecks which has led this system to collapse. They had a huge cholera outbreak. I didn't want to mention that, which has taken the life of 4,000 people. Huge measles outbreak, which has taken the life of 1,600 children. I didn't talk all about it, but I talked all about this one. And this suffices to talk about the health system, whether it's collapsing or not. And we did now what we call evidence-based planning. We did the health system bottleneck analysis. This was based on the situational analysis. And then the next step was to do health system bottleneck analysis. Which are the major health system bottlenecks that has taken this country to this kind of crisis? So this is the example that I'm going to talk about what we did in Zimbabwe. So we tried to do supply side health system bottlenecks. The supply side health system that we know, and I'm going to talk later on. The next one was policy gap for MNCH. What are the major policies? I can give you one example, which was a challenge for me to change, but we did it finally. Was when I went there, the postnatal care was starting on day 10. Day 10. Imagine. Maternal neonatal days takes place in about 50% in the first 24 hours. 75% of maternal and neonatal days in the first 1 week, but postnatal care was given on day 10. The game was over. There is a huge policy gap. If you don't address whatever investment you do, they will not go far distance. So you have to change this policy, and that's what we did. Doing policy analysis is an extremely important exercise. In addition to situational analysis, in addition to health system bottleneck analysis. Then the demand side health system bottlenecks. You can fix all the supply side. Health workers are there, supply is there, commodities are there. But if mothers are not coming and utilizing, if people are not coming and utilizing, then again it is a wastage. So you should also do a demand side bottleneck analysis and address the demand side bottlenecks. And the last one is what I call effective quality coverage. You should also check the quality of service. Mothers may come, everything is available, but the quality is bad, like what I saw some few months back in DRC. I went there. In institutional delivery, 86%, one of the best in Africa. In institutional delivery, the coverage is 86%. Drugs, oxytocin, antibiotic, magnesium sulfate, they are all there. But maternal mortality ratio is 860. So what's wrong there? You have the supply, the doctors are there, drugs are there, mothers are coming to die. Because the quality of service is a challenge. So these are the major challenges that you have to investigate before you embark upon what we call evidence-based planning. That is very critical. So these are the known, the tenacious. You guys know better about this, all details. What are the supply side bottlenecks? What are the demand side? The three supply are what? Are availability of essential commodities, human resource, physical access, health facilities, the district hospitals, the primary health centers, regional hospitals, and so forth. And then demand side, what we call the initial utilization, timely continuous utilization. It's not merely enough to come for antenatal care 1. They have to go up to antenatal care 4. That's what we mean, timely and continuous. It's not enough merely to come for DPT 1. They have to go up to DPT 3, measles immunization. So these are what we call the demand and supply side. And the last one that we try to analyze was what we call analysis for effective quality coverage. So this is what we did for Zimbabwe. Based on the tenacious classification, we did what we call bottleneck analysis. So the three major bottlenecks that we identify for maternal and neonatal, for each program you can do that analysis. The tool, what we call the tool that I haven't mentioned, what we used for the first time, I used it in Ethiopia. This tool is known marginal budgeting for bottlenecks tool. It's called MBB tool. Now they have upgraded to One Health tool. You must have heard about One Health tool. So it's the same tool, but a bit upgraded now. So we did using that, and this is what we found. And we went back to donors, to the minister, that if you don't address health commodities, if you don't address the human resource, if you don't address the quality, then you cannot reverse this trend. And the donors were asking me then that Assaye, we are really very much interested to support this country. It's so sad that the maternal mortality has tripled. We have to do something. And I told them, if you are serious about this business, then we need to act on those. And I made a brown bag. You want to ask? Yeah.
I was wondering if you could help me to interpret this. So the yellow part, is that the gap?
That's the gap. The gap. Initial mothers, you know, in Zimbabwe, as I told you, in the 90s, they had the best. They have that culture. Coming and utilizing was not a major challenge. They're coming. They're coming to die. They're coming to cry back. And that's what was happening. So this was exactly what we saw in that exercise. The essential commodities, because donors were putting 48 million for essential drugs. Relatively, that was also in a good state. But it was a wastage. That's what I told the donors. It was a wastage. Drugs are there, they're expiring because nobody is utilizing them. And that is a trick. You know, unfortunately, unlike the other health sectors, the health sector is what I call all or none. You have to do all the pillars. Doing alone one of the pillars or two of the pillars is a wastage. It's just a wastage of resource because it is all or none. The whole package has to be there to save the mother. And I'll discuss later on. In addition, my task as the chief of health and nutrition UNICEF was to voice for the voiceless, for the mother, newborn, and children. So I really wanted to see within the existing budget, health sector budget, how much of it was going to the maternal and child health program. And this was what we did, what we call resource mapping. So when we did resource mapping, only about 10% of the budget was going to maternal and child health. Almost everything was going to curative health sector budget, curative, HIV, and others. Of course, HIV is extremely important for Zimbabwe, even for the mother. But those critical areas like managing hemorrhage, eclampsia, peripheral sepsis were not addressed. And the budget was so low. So that is how we design what we call Health Transition Fund, a pool funding mechanism to address maternal, newborn, and child health problems in Zimbabwe. Pool funding. Donors, DFID, EU, Norway, Sweden, almost all major donors came and put their money into one basket. We called it Health Transition Fund. And that's how we designed it. Immediately after I made a brown bag presentation, we were able to convince and produce that. So here is the point now. Now in Zimbabwe, after doing that health system analysis, health system bottleneck analysis, this is what I presented to donors for the HTF, Health Transition Fund donors. Because they were willing to pay for essential medicine, but they say human resource and health service financing should be supported by the government. But the government was not doing. They don't have the capacity or they are not willing to. But who is paying the price? It was the poor mother and children who were paying, for none of their fault, who were paying the price. So I told them that you take out this leg from this stool, you will see what will happen. So it is all or none. Either we support these legs, they're there, or don't do it, for that matter. And that's exactly the argument I put then, 2010. Fortunately to us, and initially I was talking that this is mission impossible. When I read there 2010, I say, no, I have to go back to my place. Mission, you cannot do anything. But the day we managed to convince donors they have to put money for these programs was the day that opened an opportunity for most of us. And they gave us around 400 million over 4 years period. 400 million, probably one of the very good investments in the development world. So finally, what happened? Now this is what we saw. It gave us money for essential commodities, medicine, and the coverage suddenly went up. By the time it went up, I took the ambassadors, the consulars down to the health center and first to show them that the drugs are available there, because I had a special assurance mechanism to make sure drugs are available at the health facility. But you have to develop that confidence that it is true the money is used for the intended purpose. And that's what we did. And this is the essential medicine, suddenly a jump start kind of coverage that we have started appreciating. Human resource, again another one. The Health Transition Fund supported the health worker retention scheme. We used to call it retention scheme. To 22,000 health workers, top-up allowance. It took us days to convince donors to do that, but there was no other way of doing this business. No way. You have to retain health workers. How much drug you buy? I have shown them. 48 million annually they were investing, but there was nothing happening. Maternal mortality was going up. So these are the critical factors that we started. And in fact, for district doctors, critical managers, we had even a special allowance to retain them at a rural district hospital level, to reopen the operation theater, make them functional. As a result, the number of doctors at the district hospital, from 70, it jumped to 138. 60% of the district hospitals were closed because there was no doctor. Doctors were moving to Botswana, to Namibia, to South Africa. There is no other way of doing that business. So the moment we provided that special allowance, you can see the change within a very short period of time. And we opened, that was another critical area. We opened around 15 new midwifery schools. And the number of midwives jumped with over 4 years period from 450 to 3,500. It's a 1 year training, you need to enroll registered nurses, train them for 1 year and they become, and that's why we managed to really make this number very high within a very short period of time. In addition, although demand was not a major challenge, we trained around 7,000 village health workers using the Health Transition Fund. This is how we address the health commodities and the human resource, the second pillar that I've shown you. And now, this was another challenge to convince again donors. How much is enough for this guy? That's how they were talking about. How much is enough for this guy? But then I went, no, we have to pay for running cost of the health facilities. Running costs for primary health centers, running costs for district hospitals. And the scenario I gave them was, now let me give you a scenario, that a mother comes midnight, which is normally that's how they come, midnight with ruptured uterus. The doctor is there, ready to do the operation because we are paying him now. Drugs are there because we are paying for them. The midwife is there because we train them and we are paying the top-ups. Everything is ready. But they were told that the fluorescent light is not working. The fluorescent light in the operation, because nobody paid for the electricity bill. Regardless of all this effort to pay the doctor, the drug, and so forth, this mother is going to die because you don't have the light to do the cesarean section, the operation, the hysterectomy. She is going to die. And Paulo is still there in Zimbabwe. He said, Assaye, you are so difficult. But that's how it is. The government is not paying. That's why they are dying. So we started paying running costs for each health facility, primary health center, district hospital, every month. And I had Crown agent doing the verification to make sure that they are receiving them. They are getting the money. It was an intensive exercise, and this was what we paid. And therefore, the three pillars, the three legs that I have mentioned, were covered. And that is how we were able to galvanize change in that difficult circumstance, which was once called Mission Impossible. And Liverpool School of Tropical Medicine came to do an independent mid-term evaluation. I just took snapshot. Antenatal care jumped. Skilled birth attendants jumped. Comprehensive emergency obstetric and newborn care went up. Postnatal care went up. At this juncture, I was not worried that I'm going to impact mortality. And I had the confidence. Now, yes, we're going to make it. It's moving. It's totally independent. They came in and they did it. So now you will be happy to hear this story. So now for the first time, after 20 years, we were able to bend the curve, the maternal mortality ratio curve. First time after 20. This is what we call evidence-based planning, my dears. If you do it properly, you can anticipate a change. I didn't have a doubt, although some of the donors were telling me, Assaye, we're worried here and there, but I didn't have. Over the course, I knew we're going to reach this destination. So we did the same sisterhood method. The DHS uses a sisterhood method that you all know. And from 960 it went to 640. There was an independent global modeling which shows from 740 to 470. And the census, the three independent evaluations have shown exactly almost a similar kind of result. It was a celebration. But I can tell you in between, it was a serious challenge. One-on-one, back-to-back, those discussions. But the basis, the rationale behind this result was what I call evidence-based strategic planning, trying to address the root cause of the problem, both from the epidemiological side, from the supply side bottlenecks. We address them, and this is how it is. Now, I'm going to share another experience from a different context, how we approached the demand side bottleneck. In this scenario, in the Zimbabwe scenario, the anatomy was there. You know, when we went there, I could see that 2 months of quick and dirty assessment has shown us that the anatomy, the structure was there. What was missing was the physiology, if you like. But they were not fully functional to do the job. But there are other countries where even the anatomy is not there, like my own country, in Ethiopia. The structure was not there. We didn't have health facilities, adequate health facilities. We had health facilities, of course, but they were not enough to achieve what the minister was asking. Assaye, we have to do it. We have to make that this country has to achieve MDG. How? That was the question we asked. How? So we were forced to find a shortcut way of doing that business in that kind of scenario. In that kind of scenario, we said the only way to reach to the MDG 4 goal is to have a community-based health service delivery system. Outsourcing this to the community, establishing a very strong community-based health service delivery system. That's how we approach, because within the next 5-10 years, we knew that we cannot have the hospitals, we cannot have the primary health centers, and so on and so forth. We cannot train doctors within a very short period of time. So we said, this is how we need, and we designed what we call the health extension program. I'll talk later on. So the demand side health system bottlenecks, what we found when we did, I told you, we did both demand and supply for Ethiopia, and demand and supply for Zimbabwe, but we focused the supply side in Zimbabwe and demand side in Ethiopia. So the demand side bottlenecks were what? Number one was healthcare seeking behavior. Poor healthcare seeking behavior. You have to go and change your mindset. You cannot go far distance without that. The second one is social and cultural barriers. Even if they want, there are a lot of barriers. The gatekeepers are there to block them. Distance and transporting, financial barriers, user fees. Healthcare providers' behavior. They travel all the distance from all the way, and ultimately they have to be harassed, humiliated, and they have to see all that, but they will never come back again. And the quality of service. If mothers, babies are going there to die, definitely nobody will be willing and happy to go back to this health facilities. So this is a photograph I took in Liban, Borana, in my country. You can see that house now. How do you bring those high impact interventions to this place, to this house? Those maternal and newborn interventions to this place. That is a challenge. That is a real challenge. So you have to find a short way. So I remember then what I said was, if the mountain is unable to come to Muhammad, Muhammad has to go to the mountain. That's exactly what I said. So the only way is we have to go to them. And I am sure this mother, this baby from this house will have a problem to come to us. So that was the approach that we designed. So the approach we designed was to address the demand side barriers. Training community health workers, training them to do at least the low-hanging ones, to collect the low-hanging fruits, to do the basic ones. And that was the discussion we had. Even the minister then said, no, Assaye, this program should be a drug-free program. I said, no way. No way that we should be a drug-free, because it is a leisure for us. For that poor country, it was a leisure. That to say, no, you are only on promotion and prevention, and the other ones will do the, no. So we said, no, we should delegate. We should do task shifting. And then we said task sharing is just to treat the politics of pediatricians and others. But anyhow, what I need to emphasize here, what you need to do when we talk of community, and I did it like 1 month in Nigeria, I said, that's what you guys need. In one of the states I went, and I said, that's exactly what you need to do, is what I call TSS. It's not toxic shock syndrome that we know in medical books. No, that's not. It is training, supply, supportive supervision. If you train them properly, supply them the necessary utility kits that they need, and if you provide regular supportive supervision, they can do miracles. We have seen that in Ethiopia. That's exactly what we did. And nobody could not believe that. We trained around 32,000 in the first 2 years, 32,000 community health workers. That's how somebody was asking me, why you left the academia? That's why I left the academia. I left the academia after 15 years of my very much beloved work, joined UNICEF to translate those ideas into action. By 2010, nobody could believe it, what we did. 32,000 health extension workers, 15,000 health posts, well supplied, well trained, and supervised. And I didn't have any doubt that they will make the change. We didn't have. So that's how we did in Ethiopia. The rationale I have already mentioned. So the philosophy behind when we started the health extension, where I was involved in the design of this health extension program in Ethiopia, was if the right knowledge and skill is transferred to households, they can produce and maintain their own health. A lot of things. If you really empower them to do hand washing, breastfeed their babies, you don't need those medical doctors. You don't need those midwives for most of the low-hanging interventions. So you can empower them, and that's exactly what we did in Ethiopia. So that's how we started the health extension program. I mentioned the TSS. So the critical task, as I said, initially we had a few months of dialogue with the minister, but finally we agreed that they will do health promotion, preventive activities. They were able to immunize all vaccines, and they were able to do antenatal care and selected curative interventions. Initially the minister said, no, okay, they can treat malaria in those malaria endemic areas, And then we added diarrhea. Took me 5 years to convince them to add pneumonia. And now they are doing newborn sepsis, for your surprise. So that's how we evolved gradually, and they have done the miracle that I have mentioned. So training and supervising women development armies. We have, the extension from health exchange workers at the household level is what we call women development army, who are, the early adapters, innovators in each household, who are really considered to be change agents. So these are just the photographs of their activities, the prevention, the social mobilization, the treatment care provided by the health extension worker. These are the community health cadres who are really doing a lot of stuff. Finally, by just addressing those demand side barriers, by doing a lot of those preventive activities and selective curative activities, I was invited in 2013 from Zimbabwe to attend a launch when Ethiopia announced to the world that it has achieved MDG for 3 years ahead of time. That was a miraculous change. And that was mainly because of that approach. So now the secret is what? Evidence-based planning. If we have started, not only this country has to start constructing or building primary health center, district hospitals, we'd have never gone any far distance. Addressing the right bottlenecks at the right time with the right context, that is what we call evidence-based planning. So here you are. This is a globally acknowledged under 5 mortality trend in Ethiopia. That's how it went. From 204 in 1990, that was a baseline year for the MDGs, and went down 2030, the one that I told you was 64. Fully achieved, and now they are talking about 55. Dramatic change. Meanwhile, they have continued constructing, building primary health centers and district hospitals. And now they are trying to address the supply side bottlenecks gradually, because it's no more low hanging for them now. They have to go up, they have to climb up, they have to do quality, they have to improve. So those are the 2 experiences I wanted to share with you, to just generate appetite of how you can develop evidence-based planning in those resource-limited setups. Thank you so much. I think that's where I should stop.
That was great. I think we have time now for some discussion. That was a lot of very inspiring stories, just to get an idea of how you can change systems at a very big scale. I'm sure there are questions.
Fascinating information. Recognizing the emphasis in your research in the 20-year span on the rural areas, as you know, similar to what China has gone through 20 years, we're seeing mass urbanization in the next 20 years in Africa and India, South Asia. Curious on what you see, even the revised Millennium MDGs of the UN is focusing more on some of the urbanization issues in maternal health and healthcare, not to negate still the demand for rural treatment, but the issues of urbanization. So that's my question: is that where do you see the findings of your research applying in the next 15, 20 years in the urbanized setting, as we see huge issues? Nairobi, well documented with the issues of maternal health in the slums. They've had a huge increase in the last 5 years, expecting 400% increase, I think, in the next 10 years.
A very good question. That's very good. Yes, that's what now the ministers in those developing countries are discussing, to be honest. That's exactly the topic, the current topic. Shall we continue focusing? What now? The question, there are two questions that they are really currently discussing. One is quality. How do we improve quality of service? Because as I said now, It's no more low hanging. So they have to address quality, and the quality demands a lot of stuff. And the second question they are discussing is equity, still disparities. And now the disparities that we have been talking before, and I was trying to mention, was between rural and urban. Now the disparities are there even within the urban areas, between the urban slum and the other population. And that's what now they are discussing. But to be short to your answer, for the next 10 years, I still believe the major disparity is between rural and urban. But it doesn't mean you have to neglect the urban slums. As we move further to the next 5 years and 10 years, definitely the gap between slums and the other part of the urban population is going to grow, definitely, I am sure. But you can't make a kind of, a twist now to addressing a disparity between urban slum. No. For the next 5 years, 10 years, I still believe that more than 60% of the population will reside in rural areas, in those developing countries, particularly in sub-Saharan Africa, the region that I know very well. So that is where we need to focus. But you can gradually move to addressing the urban slums, because there are maternal and neonatal and child diseases that are really increasing in those geographies also. Yeah, that's right. Yes.
I have 3 questions, if that's all right.
No problem.
I think 2 are short. I wondered if you looked back and looked at the average cost per community health worker. I think there's been a bulletin in the World Health Organization recently that sort of suggested that it could cost something like $6 per community health worker to provide services throughout sub-Saharan Africa. I think that was the number I saw. So one question is, do you have an idea about what the cost per CHW trend?
I don't remember exactly per each. For CHW trend we have, that was less than $1
I mean, not
for training.
Per effective community health.
Yeah, I can tell you only the what we used to call it incremental cost, from whatever we had. What were the additional? In fact, I had always a story to share with the total incremental was 350 million US dollars per annum for Ethiopia. So I went and presented that for Ethiopia to achieve MDG4, we need 350 million incremental cost. And the minister was so shocked. He said, "Assaye, what are you talking about?" Then I had, a pediatrician, neonatologist talking about health finance. That was the right thing to do. But anyhow, then I discussed with the health economist from the World Bank. He said, "No, never talk absolute figures to these ministers." So the next time, I went and presented, said what we need to invest is an additional of 3.4 per capita. Yes, but it was the same figure. When you present like in a country like India, Nigeria, Ethiopia, you have to talk about per capita incremental cost. Never talk about that was the lesson for me. Never talk about the absolute figures. If you go to UP and say 2 billion is a lot. No, but in real sense, 2 billion for 200 million becomes what? $20 per capita per year. So those are, so the figure that we calculated was $3.5 per capita per year.
So that leads to my second question, which is who paid? Was it all domestic resources, or did you also get some external funding?
Yeah, that's a very good question. 80%, unfortunately, 80% was from external sources. It was only 20. The training, the health extension program training, we paid it. The government paid it, the training. But the running costs were the most expensive one. We paid the training, we paid the salary. That was a huge commitment that none of the African countries have taken place, by the way. A huge to train and pay them was really a serious commitment. And I told them, and I did like 2 months before in Nigeria, I told them you have to pay the salaries. I went there as a Gates Foundation to support them, and I told them, we can train for you, we can supply them, we can establish a supportive supervision system, but you have to pay the salary. If you want to make it sustainable, that's the only way. And that's exactly what I said to my government then. Now you have to pay, they paid the salaries. 32,000 health extension worker salaries, they paid it. They paid for the training also. But the running costs, those continuous supplies, what we call utility kits, the external support was there.
And then my third question.
Yes, go ahead.
Is what kinds of factors or what process will the government use now to decide what to invest in next, right? So you talked about the low-hanging fruit.
Yeah.
What, like a little insight into how will you prioritize? What's the most important information or set of information?
Yeah, no, that's what I tried to say. Now, again, you have to go through the same process. That's what they did, by the way. I was invited by the minister, by the Ethiopian minister, to go and advise them when just 1 year, 8 months before, when they developed the new, what they call health sector investment case, the new 5-year strategic plan. And I told them exactly to do exactly the same what we did, but using not the marginal budgeting tool. Now that tool is upgraded and it's now called One Health tool, to use One Health tool to develop their strategic plan. They did exactly the same thing. What are the supply side bottlenecks? What are the demand side bottlenecks? How are you going to address them? What is the status of coverage? And what will be the additional or incremental cost that they have to calculate and mobilize from both external and domestic sources? So that's exactly what they did. Yeah. Any other? Yes.
Can you speak to the intersection between politics and health? The confidence that is driven by personality-based politics, but we need to strengthen systems in order to be sustainable.
Yeah. That's excellent. That's another difficult area. I mean, you have to navigate politics. In fact, that's the most important. The reason why Ethiopia achieved it, to be honest, there was commitment from the other side, political commitment. Yeah, that is. It becomes very, very bitter when those what I have mentioned, who are not really active in the politics, are paying a lot of price, particularly the mother, the newborn, the children. So you need national champions for that matter, who have the courage to go out and openly talk about these issues, both in the parliament, in the government, everywhere. You really need those kind of champions. And that's what I said when I was telling you when I was in Uganda. I was in Makerere to develop the regional guideline for postnatal care. And that's what I was telling my Ugandan colleagues when they asked me, how did you guys, Ethiopians, what did you manage? And I was telling them that some of us took the courage to take a risk and to expose those politicians that they should really invest in the health sector, and particularly in maternal, newborn, child health. And those are not an easy thing to do. You have to go and face it and develop. There's no really roadmap that I can tell you, this is a way that you can do it honestly. It is totally context specific, and you have to address them accordingly. So, but the question is the most important. Without political commitment, without political will, without changing their mindset, you will not go far distance, believe me. I have seen that in different countries. And that's what is happening in DRC. That's what's happening in Pakistan. That's in those all fragile states. But unfortunately, who is paying the price? The mother, the newborn, and the child. That is a sad story. And that's exactly the major challenge. Yeah.
My second question, how do you, the platforms that you have now, catalyze those champions?
Yeah. Yeah, I know, it has given me a power, and I always said this is a divine act I'm given to this opportunity now. And with the foundation, the foundation voice, the foundation, this thing is really a good opportunity. I mean, I have already started doing that in Nigeria, where I was told that for the last 3 years they have been investing, but nothing is coming up, and they were planning to shut it down because it doesn't work. I said no. For me, and exactly what I told you before, for me, there is no mission impossible. I said I will go and do a quick and dirty kind of assessment. I'll come back and advise you. We did exactly the same thing, and we are going to try it. So I'm going to use this experience, and at the same time the voice from my coaches Yeah, we have that energy to push some of the agendas. Fortunately, most of these Africans, the coach's voice or the foundation's voice is really good. So you can use that opportunity to influence those politicians and make changes. In Nigeria, I think I have a sense that we will be successful, at least to have a model state where the others can learn and replicate those interventions. I'm very much encouraged. I went there. The feedback I got, we talked with the governor, with the state health guys. I was so encouraged. And I made a lot of this kind of, not exactly the same presentation, very similar presentation that I shared with them. And they were very much open. But let's see, everybody say, oh no, you have to be very careful, kind of, but I'm very much optimistic that we can make change. Yes?
I'm just curious, as you're building the infrastructure, and I would imagine that in Zimbabwe, to get, since it's more centralized, to get some of the data back on the metrics of how you're doing is a little bit easier than in Ethiopia when you have the communities, and how do you build that in, or is that just part of building the structure? Are you able to get that data back so that you can make the changes?
Very good. Yeah, that's excellent. Again, another excellent question. For me, monitoring, evaluation, tracking progress is the lifeblood of this program. You can't do otherwise. Have to be frank, and we made sure that it was part of the design from the outset. I did that in Zimbabwe. I did it in Ethiopia. That's where I started, in fact. So it made our life easier to collect some of the data. But if you ask me, even now, one major challenge in Ethiopia, right now, I was 2 weeks before there in Ethiopia, we were discussing exactly the same data. They call it now data revolution. There's still a huge gap with A, quality of data, although they are getting, B, the capacity to analyze it, C, the capacity to use it for decision making at a local level. These challenges are still there. But there's a lot of progress from what we were some 10 years before, but that's again another important, that should be part of the design from the very beginning. And we have been emphasizing that. That's an extremely important point. Yeah, that's right. Yes.
I was wondering if you could talk a little bit about the trade-off or the balance between a really specific targeted approach and a more horizontal approach in terms of the outcomes that you're trying to address, and how this process would adapt to either a very specific focus or a more broad focus, given that the evidence that you need and the approach that you take would differ based on what outcomes you're interested in changing. I mean, clearly, with maternal mortality, it's sort of a proxy for the health system overall, but how did you determine in each particular environment what to prioritize in terms of needs, given that, what is necessary is going to depend on what you're trying to change?
Yeah. Again, another. I was supposed to talk for about 2 hours, to be honest, today. Because that is one area, one topic, 1 hour, 2 hours talk of what you have asked now is, there are about, so for some of you who are clinicians, about 15 different causes of maternal deaths, about 20 different causes of under 5 days. But we were not interested to address all of them from the very beginning. We were supposed to target what we call the major killers. That's why I said in one of my talks, situational analysis, where you define the epidemiological profile. What are the 3-4 major causes of death, of maternal death? What are the 3-4-5 causes of under 5 days? Maternal, globally known now. If you go to Nigeria, Ethiopia, Zimbabwe, they're the same. PPH, pregnancy-induced hypertension, eclampsia, preeclampsia, peripheral sepsis, obstructed labor, abortion. But the abortion is more in DRC than in Nigeria, but they are well known. So you don't need to go to address 20 and dilute your limited resource. So you have to focus on those major killers to get the huge impact that we've talked. The same holds true for under 5. Again, the same thing. What are they dying? Newborn problems, pneumonia, diarrhea, malaria, and measles. Malnutrition as an underlying. That's it. You don't need to go to congenital anomalies, to a lot of rare events. So you have to be focused. That's what public health is all about. The difference between we public health professionals and the clinicians, I was once a clinician too, for them every year rhabdomyosarcoma is a case that they have to deal with. But for us, what are the major causes of death? That's the term we use, major cause of death. So you need to target, intensify, to get a public health impact in the end, better outcome. That's how exactly we were able to achieve both in Zimbabwe and to target, very much targeted, very much focused in those major areas, major killers. So that's how we managed to see those impacts. Yeah, you're right. Yes.
Following on that, you talked about integrating services, sort of taking advantage of sort of a program that's already there and adding things in.
Yeah.
How do you make decisions around, or do you have examples of situations you don't want to dilute the core sort of mission by adding too many things in, watering it down so much, but you can gain a real efficiency by selecting the right added services to go into that? Do you have things that you look at in terms of making those decisions, when to add services in, what types of things integrate well together?
Very good. I was just advising my colleagues in the foundation recently, and they were talking that now we have to intensify asphyxia. Now almost 52% of global under 5 mortality is due to newborn problems. Okay, so we said, okay, we have to target the newborn problems to get the impact in the next 50 years for the Sustainable Development Goal. And we found that one major cause of death is asphyxia. And we said, let's intensify asphyxia. Now, when you talk of asphyxia management, for some of us who've been doing that, you don't do asphyxia alone in that what we call essential newborn care package. You don't prepare yourself for asphyxia. During that period, that few minutes and few hours period, there are a lot of other intervention where you can get a free ride. So don't talk of asphyxia alone, although your target is asphyxia. Then you have to talk of what? Thermal care, immediate drying, which can be included in the asphyxia intervention package. What else? Early initiation of breastfeeding, which is one major high impact intervention that you can package it to the asphyxia package. Delayed cord clamping, again, is part of the asphyxia. So you have to think like this, and that's how you need to package them. That within that period of span time where you can do neonatal resuscitation, there are other, without really putting a lot of investment, that you can do. Early initiation, kangaroo mother care, delayed birthing, delayed cord. Those are the things that you need to package them. So without diluting, as you rightly mentioned, without stretching, without putting additional cost, you can package them, and the result will be 2 + 2 is more than 4, kind of this thing. So that's how we are now trying to package, and that's what I'm trying to advise them. Instead of focusing, let's do this, let's do that, package them at each level. During antenatal care, you can package some of the nutrition intervention, some of the emergency obstetric care intervention, package them during antenatal care so that the mother benefits to the maximum. That's the kind of approach that we are doing. That's, again, a very serious point of discussion where you can have. It's much easy said than practiced, because I have seen the challenge. There are a lot of challenges there. Yes, madam.
So I was wondering, and this follows on some of the comments and questions that other people have asked about the sustainability, since both of the programs that you described are so dependent on external events. It seems like you had good support from the government, which is great, wasn't everywhere, right? But how about the sustainability?
Yes, you're right. I mean, that question, if I have counted it, it must have reached by now about 1,000 times all over when I presented. One person says, yeah, it's a very critical question. That's an important question. What is now the plan? So what? When you step out, then everything goes back. So what will happen? Yes, we tried to design. From the outset, we tried to address that issue by allowing the government to put 10% of the total health transition fund budget every year. By 10 years, they will take over the whole responsibility of running this program. Now somebody, macroeconomist guys, will come and tell me, hey, Assaye, don't be that ambitious, because it all depends on the macroeconomic situation of the country. You know, if the macroeconomic situation is not picking up, it's not showing improvement, then where do they get the money to come and plug in? So again, it all depends on the recovery, the economic, the overall country's development. Ethiopia is now mentioning that they are moving to mid-level kind of economic achievement. I don't know how far and how feasible that is, but again, it is really showing a significant improvement. And as I say, the salary of the health extension workers was paid by the government. So they have already shown a lot of commitment, and investing on community health workers is not that expensive, as I told you. So that should not be really a challenge. The challenge now is if they want to push the graph down, then community health service delivery alone is not enough. So they have to start to invest on a higher level, primary health center level, district hospital level, to further push the maternal and child mortality graphs down. So that's the challenge, and again, it remains a challenge until they come out of those poverty curves. That's why the SDGs emphasize more on economic development and other stuff. But that's an important question. You're right. Yeah, I think.
Thanks again. That was fantastic.
Thanks. Thank you. Yeah.